hello and welcome to our today's discussion, and that will be launching the final report of Stop AIDS and Just Treatment's Access Denied report series, Extractive Research and Development in the COVID-19 Pandemic. My name is James, and I am an advocacy manager working at Stop AIDS based in the UK. I'm delighted to be chairing today's meeting, which has been co-organised by Stop AIDS, Just Treatment, and the Initiative for Social and Economic Rights Uganda. This meeting today comes at a very important time, as delegates are meeting today at the World Health Assembly, negotiations on a pandemic treaty continue, and of course, yesterday's publication of the UK's Global Health Strategic Framework. But crucially, this discussion comes at an important time where we must be better learning from the mistakes made during the COVID-19 pandemic. As 3 years on, the pandemic has officially caused the deaths of over 7 million people, with excess mortality stats putting this number nearly 2 or 4 times higher. The pandemic, as we all know, disrupted global livelihoods and continues to have a devastating effect on communities without widespread access to health technologies. The world's response to the pandemic demonstrated the flaws in the global system for the research, development, and dissemination of health technologies. Our Access Denied report series, through legal and investigative research, explores how UK, EU, and pharma companies' decision-making contributed to the gross inequity we have seen in access to COVID-19 health technologies. Each report is part of our series, which I recommend checking out if you haven't as yet, sets out recommended legal and policy options to improve transparency and public oversight to ensure that access to health tools during pandemics and beyond is never denied again. Please do go onto our website and see all the other reports if you haven't already. My colleague Olivia will be now posting some links in the chat to see the other reports part of the series. But today, we're delighted to be launching the final report of the series, which details the role that UK public entities have played in supporting the development of COVID-19 tools. It highlights how the lack of equitable access safeguards across the research and development continuum results in with the perpetration of an extractive global health system that compounds existing health inequalities. Whilst this report focuses on the actions from UK government and pharmaceutical company decision-making, we also highlight in the report the massive global implications of the decisions and the strong parallels there are, of course, to the actions taken by many other high-income countries. So it's great to see many colleagues joining from around the world for this meeting today. I'll be shortly passing on to one of the co-authors, Dr. Manuel Martin, to present on the research, who alongside his co-author, Rhiannon Osborne, did a really amazing job at researching and writing the report for Stop AIDS and Just Treatment. For those who don't know him, Dr. Manuel Martin is a medical doctor working on access to medicines and policy and research. He's worked for many different organizations to improve access to health tools, including with us at Stop AIDS, Doctors Without Borders, and the People's Vaccine Alliance, among others. Throughout the COVID-19 pandemic, Manuel also closely followed research and development issues in his capacity as a policy advisor for MSF. Following Manuel's presentation, we are really excited to be hosting a panel discussion with some leading global access to medicines advocates from around the world. So firstly, Labila Masako, Dr. Bajo, Alan Silva, and Asia Vasi. Labila is a program officer for the Right to Health at ISA Uganda. Labila believes firmly in the power of accountability, equity, and justice. It's definitely the right person for today's discussion. She's not afraid to broaden both her personal and professional networks and perceives everything in terms of the place in the system, its inclusion or exclusion, and how to ensure the system works for everyone. Dr. Elia Bajo is a doctor working in the city of Goma in the Democratic Republic of Congo, DRC, and is director of Council on the Health and Academy of Medicine. This is a health agency working with vulnerable communities in DRC and including the region with the second highest rate of infections during the COVID-19 pandemic. And as you may see in the report, when you have a chance to read it, Elias shares his really powerful case study with us in the report. Alan Rosa Silva is a staff attorney at the Brazilian AIDS Association, ABIA, serving as the coordinator of international affairs at the Working Group of Intellectual Property of the Brazilian Network of the Integration of Peoples. Alan is also pursuing a PhD in law at the State University of Rio de Janeiro. And finally, last but not least, Asia Vasi, who is a farmer organizer at Just Treatment, working on the COVID vaccine equity campaign since January 2022. Asia works on engaging individuals from diaspora, minority communities, and clinically vulnerable patients who've been impacted by vaccine disparity. And following this panel discussion, we're of course really keen to hear from everyone joining today. So there will of course be an opportunity for questions, discussions for Manuel and the other panelists too. But before passing on to Manuel to take us through his presentation, I'd like to firstly thank the Open Societies Foundations for making this research possible, co-author Rhiannon Osborne, who sadly couldn't be with us today, and of course all colleagues globally who supported with the research and this consultation as well too. But without further ado, I'd like to pass over to you, Manuel, and I'll load up your slides.
Wonderful. Thank you, James. And I'll join you in just also acknowledging my co-author, Rhiannon Osborne, and also to thank everyone who contributed to this report. I think like the best research and development, this was a collective and collaborative effort. Wonderful, thank you. So to get started, this report is structured in two separate parts. The first part covers an analysis of the overall public support the UK specifically provided for COVID-19 health tools. And the second part covers 6 case studies, which look at specific COVID-19 health tools that received some form of public support, and whether or not, and also how, if at all, this has translated into equitable access. Next slide, please. So it's important, I think, when speaking about this, to put the COVID-19 pandemic into a kind of historical context of public funding for both global health R&D and more narrowly emerging infectious disease R&D, sometimes also referred to as pandemic preparedness R&D. And it's important to kind of acknowledge here that globally, public entities have always made up the vast majority of funding in this area. So data from 2014 up until 2020 shows that around 80% of the total funding in this area has been provided by public entities. So this is really a space that has traditionally belonged in the domain of the public. And since 2017, the UK Department of Health and Social Care alone actually has been one of the top 10 funders in global health R&D. So this is zoomed out even a little bit further. As you can see from the graph and also from other statistics, there was a really drastic increase in funding for emerging infectious disease R&D and global health R&D. This increase really was due to the COVID-19 pandemic, and drove really an increase that was 560% of the 2019 funding in this area. It's, I think, important to acknowledge that this came at a cost also to spending on poverty-related neglected tropical diseases and also sexual and reproductive health, both of which saw in that year a drop in funding. Next slide, please. As for the overall support the UK public provided for COVID-19 health tools, I think it's important to capture here that this happened through a variety of different channels and entities, and didn't just occur through a really simple, simplistic form of funding, either directly through public research institutions or just through public grants, but really covers a wide variety of channels, including, of course, product development partnerships. Intellectual property rights are also a form of support for research and development, R&D tax incentives, public manufacturing facilities and infrastructure funding that existed. Next slide, please. As for the specific spend the UK public engaged on during COVID-19, by the end of June, which was the cutoff date for the research of this report, we found that the UK RI and NIHR, two of two channels that provided public funding for COVID-19 research and development, had spent 403 and 158 million pounds respectively directly to fund the development of COVID-19 diagnostics, vaccines and therapeutics. Overall, both of these entities spent more than that. However, these were specific grants that we were able to trace back to the direct development of each one of those tools. I'll get to some of that other funding a bit later. Secondly, of course, there was the UK Vaccines Task Force, which was funded by BASE and the Department of Health and Social Care, which provided significant funding through grants and funding for manufacturing of vaccines, but also through advanced purchase agreements, which obviously included a form of de-risking as well, so can be classed as support for the research and development manufacturing continuum, so to speak. And then thirdly, another major channel through which the UK provided public funding was funding for global institutions that supported research projects. So one of them is CEPI, and since the inception of CEPI in 2018, the UK government has provided CEPI with almost £300 million for the research and development of vaccines. Some of that money supported really critical platform technologies, such as the Oxford vaccine platform, which of course then later resulted in the Oxford AstraZeneca vaccine, and also through FIND, where the UK government provided FIND with £23 million for COVID-19. Next slide, please. The other way in which the UK public provided funding or support for COVID-19 technologies is through something that we've termed catalytic projects. So these are projects that don't necessarily directly support the development of any individual tool, but really supported an ecosystem of support that enabled both research and development, manufacturing, but also the implementation of actual tools in the real world, and provided really important data also for the rest of the world. So this includes the Vaccine Task Force, which I've just mentioned. It also includes large trials and studies that were conducted that weren't specific to any one tool. I will talk about the recovery trial in just a bit. Support for global R&D initiatives that I've just mentioned. Consortia, so for instance, the UK Genomics Consortium was a really important player and was supported through public funding, and of course, manufacturing support that the UK provided. Next slide, please. Moving on to the case studies, we looked at three groups of case studies. The first ones are therapeutics, and we looked at two different monoclonal antibodies, tocilizumab and sotrovimab. They have really quite different research and development histories, but of course, the type of technology is similar. Tocilizumab had been approved for a variety of different autoimmune-mediated diseases prior to COVID-19, but actually the original development of this monoclonal antibody was supported through critical intellectual property and know-how held by the UK Medical Research Council. And through Freedom of Information Act requests, we were able to actually receive some of these collaboration agreements that really show the detailed exchange in knowledge that happened between Chugai, which was the developer at the time, and the UK MRC. So necessary to develop this monoclonal in the first place. Then a variety of different US public support, but also international public support was provided for research that demonstrated that tocilizumab could be used in other indications. Really, the list of indications for tocilizumab has increased significantly since it was first approved, and it differs by regulatory agency. And of course, the big one here is the recovery trial. This was the trial that really demonstrated that tocilizumab was of great use in COVID-19. I'll get to that just in a bit, but this is really a critical trial, and of course was supported through UK public funding. However, despite all of this public support, global access to tocilizumab was limited both by high prices and supply shortages due to intellectual property and regulatory monopolies. The UK NHS actually had to pay somewhere between 47 and 62 million pounds for tocilizumab just for COVID. So this is net of the use of tocilizumab for other indications, and also faced shortages. So patients who were reliant on tocilizumab for arthritis, for instance, weren't able to access it. Sotrovimab is a little bit of a shorter story. The discovery of it is really based on SARS patient antibodies. This is from the first SARS outbreak. And there's some significant research that was supported by the US and EU public funds surrounding that, and actually several studies prior to the approval or conditional approval of sotrovimab, showing that it was efficacious, potentially efficacious against COVID-19, were financed by the UK and US public. Again, it was included in the recovery trial. Unfortunately, the results of that weren't published, but it was included as one of the monoclonal antibody studies. And the UK NHS had to pay 62 million pounds roughly for the doses of sotrovimab that it accessed. Again, global access was limited by prices, going into the several thousands, despite a WHO call to action to ensure affordability and sustainable supply of this monoclonal. Next slide, please. So moving on to the recovery trial, I really want to take make a special mention of this trial because it stands in, obviously we all know about it. We all know what impact it had in terms of generating really important evidence for the care of patients with COVID-19, but it is also in a certain kind of way stand-in for other platform trials that were financed through the public globally. It was really critical in adding clinical value to both new and legacy drugs, and there's really no private equivalent of this type of platform trial. That really shows the unique contribution in this case that the UK public made through the recovery trial to the pandemic response. And in terms of costs, according to the NIHR and UKRI grant databases, the recovery trial received a joint grant from both of those institutions worth 2.1 million pounds. However, if we apply traditional industry estimates to the numbers and statistics of just the trial arm of recovery that analyzed tocilizumab, that places the value at 115 million. Now, there's a huge gap between those two figures. And we think that in part, this is explained by the fact that the way that industry accounts for and pays for clinical trials is different than a publicly run trial, and they don't face the same costs, showing that sometimes public run clinical trials can be far more cost efficient, but also that a significant portion of this cost was likely absorbed by the NHS infrastructure that really helped conduct the recovery trial. So we think that the grant of 2.1 million pounds doesn't reflect the actual true investment of the UK public into the recovery trial. Next slide, please. I'll only briefly mention the LFTs. We looked at two, SureScreen and Mologic. There's, again, similar technologies. These are lateral flow tests. They really have quite a different story. So Mologic is a company that took a very pro-access, kind of pro-equity approach from the get-go, and it took quite a while to find allies to help support this. Notably, it received grants from the UK government to develop their test. However, a lot of the access efforts actually weren't supported by the UK government directly. But really came from the own initiative of Mologic employees. Eventually, they were able to conduct technology transfer to the Institut Pasteur Dakar, where in Senegal, with global access in mind. The test was then available at £1.25 per test, and they provided technology transfer. So this was truly a kind of an equitable way of sharing their diagnostic test. Mologic now has changed its name. It's now Global Access Diagnostics and is now a shareholder-less non-profit dedicated to developing LFTs and diagnostics for a wide range of diseases, and is in continued collaboration with the IPD. SureScreen, on the other hand, a much more private model. They received some limited support from the UK public. like many other LFTs, the kind of critical comparative studies and validation studies were funded by the Public Health England. Little is known on global access and supply, but according to leaked contracts, the UK paid around £25 per test in the supply deal, and the test is now available for £6 commercially. So really quite a difference between the two. Next slide, please. In terms of vaccines, we looked at two, the Imperial and the Oxford vaccine. Oxford is, of course, the Oxford AstraZeneca vaccine. The Imperial vaccine is a self-amplifying RNA vaccine candidate. It never made it to licensure. However, it received significant public funding, demonstrating that the public also takes risks and they don't always play out. It received around £10 million prior to the pandemic, and then an additional 73.3 million from a variety of different UK public entities. We can't talk about access, of course, because it didn't reach licensure. However, there is a worrying development in that part of the platform has been licensed to AstraZeneca with little to no transparency around what happens to access around this platform should AstraZeneca be able to develop a vaccine using this platform. And on the other hand, we have Oxford, also mostly publicly developed, almost entirely. According to prior research, we found an additional £88 million for R&D manufactured from the UK government, specifically for the vaccine candidate. And we know that despite the vaccine being one of the most accessible and affordable globally, there were some limits to its accessibility. We know that there were some conditions placed on AstraZeneca with regards to affordability in particular, around the non-profit pricing. However, there were also limits, which meant that AstraZeneca was able to call the pandemic basically to an end earlier than the WHO did, which meant that it was able to charge for-profit prices in high-income countries early on. And this demonstrates that whilst it's possible to introduce access conditions, one needs to learn from past mistakes and kind of it's an ever evolving process, and one needs to improve access conditions and then strategies around access as one goes along. Also, a lot of this was intransparent, and it took a lot of work from investigative journalists and NGOs to get more information around actually the conditions and deals that were signed by Oxford and AstraZeneca. Next slide, please. So next slide. So in conclusion, I think there's three big buckets of things that we can conclude from the overall report. The first one is that the public support really for COVID-19 tools was ubiquitous and really impactful. The web of public support, which stretched from early basic science through all phases of R&D and during the COVID-19 pandemic, even into manufacturing, really the R&D to manufacturing continuum. Then with the R&D support that we identified often included a multitude of public entities, so often wasn't just one public entity providing it. And this was sometimes also an international effort, again, highlighting both the globalized and cross-dependent nature of public R&D. Secondly, we've found that public investment often unfortunately continues to fuel an extractive R&D system where there's a consistent failure to leverage public support for affordable access and equitable access. And the few exceptions that we have found, also highlighted in the case study, show that introducing conditions around equitable access and transparency, for instance, is possible and desirable, but the piecemeal fashion in which this was done really was insufficient. And thirdly, that public R&D from the perspective of the UK actually continues to support a colonial system. Much of the public investment which the UK is able to put into biomedical R&D actually comes from historical wealth extraction. And post-colonial dynamics play a role here too, brain drain, international trade laws, IP laws, etc. And really decolonizing pandemic preparedness, so to speak, it must include steps to dismantle these kinds of dynamics that drive equity. I won't read out the quote below, but I think you will have access to the presentation later. Next slide, please. So moving on to the recommendations. We make 6 recommendations. The first one is really to scale up investments in public health-driven research and development, linking back to the fact that this can have a great impact. Second is to introduce equitable access conditions across the R&D continuum, and that these conditions need to differ depending on where they're introduced. So conditions on equitable access very early on are not the same conditions that you would want to place at a later stage of public support that is a little bit further downstream or even in the manufacturing space. And really we need conditions all across that and to link these up. Which brings me on to the third recommendation, which is to develop and evolve equitable access strategies across UK R&D funders. Really, the piecemeal nature in which these are applied, when they are applied, really demonstrates that there's no clear, coherent strategy to access across UK public funders. And we think this is something that can be improved, and really think that UK public funders can also become learning organizations that not only have a common strategy, but continue to learn from past mistakes and obviously also successes to continue to improve on equitable access. Then fourth, ensure transparency all along the R&D value chain. This includes a whole range of different elements of transparency. I won't be able to go into each one of them, but they're contained in the report. Then to support global initiatives which actually safeguard equitable access. Honorable mention here, obviously, to the WHO mRNA Hub, which really tried to democratize an entire platform, and it was the first, I think, of that nature to try and do that, try and really address the source of the problem rather than just the downstream consequences. And then lastly, but definitely not least, to incorporate equity in international positions on research and development. And this is, of course, very important now that the negotiations on the pandemic accord are going on, and a variety of different international fora are discussing what pandemic preparedness should look like going forward. I will stop there. Thank everyone and hand over back to James.
Thank you so much, Manuel, for your and Rhiannon's excellent research for the project and presenting the findings today to us all too. Really keen to hear everyone's feedbacks, thoughts, reflections, and questions too. Please do hold on to them or put them into the chat now, as we'll be coming back for more time with Manuel for questions there as well. But as Manuel does really eloquently put out, we're really hopeful that the UK government and other governments worldwide would take on board the findings and the recommendations going forwards. As I mentioned at the start, yesterday saw the launch of the UK government's global health strategic framework that does include commitments for a global campaign for open science, for global resilience, and further commitments on the UK's approach to research and development. So really hopeful that these recommendations and the approach that we put forward gives tangible steps for how the UK can work to ensure better public return on public investment and drive forward their global health and pandemic preparedness commitments as well. But without further ado, I'd love to now begin the panel discussion with the different four panelists who we introduced earlier. So first, I'd like to turn to you, Alan, to share your thoughts and reflections of the past few years of the COVID-19 pandemic and of the reports that Manuel just presented on.
Thank you, James, and all the Stop AIDS team for the opportunity to be here today and share some ideas on this important discussion. First, I would like to start by saying that this is one of the best reports I have ever read on this topic. And I would like to say some words why is this one of the best reports I have ever read on this topic. Not only because its accuracy, of course, as everyone could see in Manuel's presentation, but also because of its methodological rigor. And I would say that the most important characteristic of this report is that it was not afraid of naming things as they should be named. And when you see the report, and I highly recommend you do that, you see that they addressed a lot of issues such as vaccine apartheid, and they use this expression in a very important way. And they also qualify the current global system as extractive, racist, and neo-colonial. And I think this is very important to highlight because this wording must have consequences. It's not just a simple way to speak about such a serious topic. So speaking from a global South perspective, I would like to explore a little bit more about what does it mean to consider the global health system as a colonial one, a neo-colonial one, and what I could extract from this report that was very clear about it, as I said. First, the report is very clear by saying that the few innovative health technologies that we have, they are not designed for our needs in the global South. And it's very important to keep in mind because this is the first intervention of the bad intervention of the IP model in the global health system. And it's the consequence of a profit-driven innovation system, so-called innovation system, because it's not even efficient, as we all know. Secondly, another characteristic that allow us to call it a global health system that is neo-colonial, and we can extract it from the report, is how this system uses literally our bodies in the global South to test as objects, sometimes to develop these new technologies. So the clinical trials in the global South is another issue that we must keep in mind. Of course, we can find just to dialogue with the examples, the case studies, we can find some references to sotrovimab and also tocilizumab clinical trials in Brazil. But of course, the main example we could cite here would be the Oxford AstraZeneca vaccine that was carried out there, as we all know. But what makes us differentiate between collaboration and exploitation? How this participation of the global South in clinical trials, for example, is an exploitation and not a collaboration. In my perspective, I would say that it depends on the third topic that is very well addressed in the report. That is the inequitable access to these same health technologies. So these technologies, they are tested in the global South, and then we don't have the access to these technologies. And then I don't have to repeat here, for the sake of time, the case of sotrovimab and tocilizumab that were completely missing in our countries in the global South. But I could, yes, address the case of Oxford AstraZeneca vaccine, because some of you could think that, okay, you had access to the Oxford AstraZeneca vaccine in Brazil, and it was widespread all over the global South. But it's a good opportunity to discuss what means access. We are not just talking about accessibility. We are demanding health sovereignty, and it means transparency. It means price. It means sustainability. It means avoid all the conditions that are imposed upon us. For example, the risks and other conditions that we don't even know that were imposed on our countries. And first and foremost, I would say that it's very important to say that it's not the case of considering just the access in Brazil. It's another trap of nationalism. It was tested in one country, it should be available and accessible in all countries, not just in the country that it was tested. So I think it's a major point that we should think about. And lastly, to conclude, the fourth point that allow us to speak about neo-colonial system in the global health innovation and R&D context is, of course, the main topic of the report, that is the privatization of public resources in the global North through IP. And here we can see IP again. After all, where do these resources of the global North come from? And this is very well addressed in the report too, when they talk about the socialization of risks and privatization of returns in a very direct and accurate way. In the end, one of the most important conclusions we can extract from this report is that when it comes to global health, nationalism undeniably equals neo-colonialism, and we must have this in mind always. Thank you very much.
Thank you so much, Alan, for your really powerful intervention and sharing reflections on the report and the research done by our colleagues. Really powerful, and I'd love to come back to some of those points further in discussion at the end of this meeting with colleagues on the call now as well. And now I'd like to turn to Asia from Just Treatment to share some reflections, looking at how extractivism impacts also patients within the UK and any other broader reflections.
Thanks, James. Hello, everyone. My name is Asya Versi, and I'm the farm organizer for Just Treatment, working on the COVID vaccine equity campaign for the past 18 months. Read the report, loved it. There was an unprecedented scientific development and innovation, which was driven by the need to create and approve a vaccine. Public funding was instrumental in research and development and the distribution of these COVID-19 tools, but the governance of access was and is outsourced to private companies that are hell-bent on prioritizing profit. This profit-driven industry entrenches colonial distribution of economic and political power, and we as organizers see a rise in health disparities both in and outside of the United Kingdom. The right to health is not respected by the pharmaceutical industry, and healthcare becomes, like my colleague on the panel just mentioned, healthcare becomes a nationalistic race rigged in favor of those who can afford to win. The system quite literally holds our health to ransom. My colleagues on the panel will speak to the impact of the high cost of medicines in their countries, but higher income countries like the UK see this corrupted system impact the lives of their citizens too. Tocilizumab supplies were limited as Roche refused to share the know-how to facilitate increased supply from others, affecting arthritis and COVID patients alike. This is seen outside of COVID too. My colleague Gail was forced to spend 4 years of her life fighting for access to a cystic fibrosis drug for her daughter that was priced too high for the NHS. This system only benefits the companies that have set it up and not the patients that need it the most. Although higher income countries exercise power to prioritize access for their own, members of diaspora communities within the UK are left grappling with global health inequity and premature deaths that they see playing out in their families across the world. Not only that, during the pandemic, we saw clinically vulnerable patients still shielding 3 years down the line because of variants that kept on coming back. The extended self-imposed lockdowns irrevocably changing their lives forever. Recently, I spoke with an unusual, honest drug company pharmacologist. He argued that the price setting is not determined by the cost of developing or manufacturing a drug, but how much a patient or client can potentially pay. It is not based on how well the medicine could improve the patient's health, but quite simply how much money the medication could make for the company. This relentless pursuit of profits claims lives, and the current intellectual property laws facilitate this. This realization needs to be more widespread and needs to be directly challenged because all our lives and health outcomes are being held to ransom by a few companies who have million-pound blinders on and refuse to acknowledge the impact of their profiteering. We've mentioned how members of the diaspora communities in the UK are impacted by loss of family members abroad and clinically vulnerable patients who rely on the good health of their community. But during the pandemic, when COVID-19 treatments were being trialed and used within the NHS, once again, it was the patients that bore the cost and risk of new treatments. Kate, a healthcare assistant in Durham, and this particular example is featured in the report as well, has rheumatoid arthritis and has relied on tocilizumab for many years. It was identified as a potential treatment for COVID-19 in September 2021, and Kate's medication was altered as the supply was shifted to prioritize COVID-19 patients. And although she was put on a reduced dose, a year later, supply was still an issue. Allowing one or two companies to dictate supply has a massive negative impact on patients who rely on the medication to manage chronic diseases and leaves them at the mercy of companies who center their work on the profits they generate. And although here in the UK, we can say we have an admirable health system compared to other parts of the world, how much better access can our patients get if our current system was reconfigured to put patient lives at the center of it and not the medicine's potential profit, which is relentlessly pursued? What if the government used the power it has when it funds the creation of these new medical products for the public good, instead of giving it away so it only benefits private interests? The current system uses members of the public for its trials. The report highlights the story of Kimberly Featherstone, who was a recovery trial patient and a teacher at a school. She caught COVID in October 2020 and was admitted to hospital soon after, and was given steroids and inhalers soon after to manage her shortness of breath. She was approached for a trial treatment of monoclonal antibodies, and it worked tremendously for her. This treatment was then approved for use the following year. The current system uses the public to diversify its risk, but its return is privatized even when members of the public who volunteer for the trial want access to improve for all. And once again, this example is mentioned in the report as well. The public sector plays an undeniable role in the development of new medicine and socializes the risk even at a trial stage. There is potential for that role to also dictate clauses that can ensure greater access for all based on the right of access to medicine and not on the ability to pay. We need the government and opposition here to heed the recommendations of this report and the others in this series, which seek to learn the lessons of COVID. We need to start thinking about health as a collective, global responsibility and not a national pursuit, because maybe then, just then, there's hope. Thanks for listening.
Thank you so much, Asif, that really powerful intervention, and I think definitely that hope for hope must keep us pushing forward as well for change in the health system and the approaches that we need to ensure the right to health. I'd now like to turn to Dr. Badger. Elia, I'm grateful to share any of your reflections on the report, and if you'd like to touch on testimony that you shared for research that's featured in the report as well.
Okay, thank you very much, James, and thank you, everyone. I was very happy to contribute to this report, one of good reports. The first one was the last one we did with Matari, which was the best one also. But this one I like because it raises a local voice of people who are on the ground, who are left behind. The first one thinks of what I shared. It's about the inequity of access to different tools. And when I say that inequity, I see people who are vulnerable. Inequity to treatment, vaccine, also to tests. Can we imagine I'm a medical doctor, but I never prescribed an antiviral against COVID-19. I never seen it in DRC INCO. Can you imagine when the number of deaths you can increase the number of deaths, but you don't have tests to know if it is about COVID-19 or not. And all that things, it raises the risk at local level, but also at the global level. You don't know, because COVID-19 doesn't need the passport to go from Goma, from DRC to UK. If you don't facilitate accessibility to those people who are in rural areas, different parts of the world, that COVID-19 will come again to you wherever you are. The problem what we have is because people, that inequity, white people, sorry to say that, people who are at enough parts took those tools for themselves, but they didn't give them to people who need them also more. They said that it's not a risk for us. But when we don't know people are died here, if it is about what, COVID-19 or not, I give the example of now, which I didn't say in the report. We did an assessment in a rural area where the infection, the respiratory disease are the first cause of death in that area, but they don't have access to rapid test of COVID-19. We don't know if it is COVID-19 or not. Till now, we don't have that access. They don't have tests. They don't have treatment. The one who would like to have tests, you must pay $5. Can you imagine? If you need treatment, oxygen, you must have at least $40, $100. An internal displaced population can have that money to pay? The response is not. And when he don't have that access, it means he will transmit that disease to another one who is near of him. And that the problem will continue to be at all the world. I think this report must contribute to raise that local voice and to say that we must prepare ourselves to make an equity in responding to pandemic disease, including COVID-19. I think I can stop first by there. If there are some questions, I'll be happy to respond. And you can read also other of my testimony in the report. Thank you.
Thank you so much, Alaya, and do strongly encourage colleagues to read the powerful testimony shared in the report and highlighting the impact of a lack of equity in access to treatment and the brilliant work that you do responding on the front line to the pandemic as well. And I think what you shared as well too, even though there's less media attention now and the COVID-19 pandemic, highlighting still the inequity you're facing with lack of access to tests and treatment presents further evidence and such a compelling case for the need for an urgent extension of the WTO decision to include COVID-19 test and treatments, whilst looking more broadly at the longer term reforms that we need of the R&D system. And now, finally, last but not least, I'd like to turn to Labila from ISA to finally share some remarks before we move into Q&A and discussion. You now have the floor, Labila. I think you're on mute though.
Yes, thank you, James. Top AIDS just treatment, and great appreciation to my fellow panelists and everyone who has made it to this webinar. I've just associate myself with our previous panelists. I'll just start off the thing by remind ourselves of the famous quote by Paul Farmer, just shortly before he passed on, when he said, if access to health care is a human right, then who is human enough to live or die? To put it in context of the reports under launch today, access denied, it resonates well with what we experienced in Uganda. As someone based in Uganda, a low-income country, we struggled to find even the basic medicines or tests for COVID-19. I witnessed people in my neighborhood die every day. You could hear sirens, ambulances, but all signaled someone had passed on. To this day, we still believe all these deaths were unnecessary and were avoidable. But because when we apply a colonial and the colonial lens to all events that happened 3 years ago, we are reminded of what everyone says, that global health is not really global. And it's one of those fancy symbols or words that are used to blind people in the global south that we are in need all together. And this also, the Director General of WHO came up after months into the pandemic and said, much as the myth is ongoing that we are all in it together, we are just floating on the same sea, while others and the yachts, super yachts, others are floating on the drifting debris. And for the global south, we're indeed on the drifting debris, where we are forgotten race and forgotten in all aspects of COVID-19 preparedness and treatment. Maybe we can recall when the vaccines were first rolled out, much as people in the global south, in the global north, including the UK government, rolled in front of everyone else and hoarded vaccines. Countries like Uganda were pushed at the back of the lane. And for some that didn't have enough resilience, were pushed out of the queue. And it took 2 years or 1.5 years to get even a first dose of the vaccine, while the rest of the people in the global north were receiving their third doses, booster doses. So if we are to take the recommendations in the report seriously, we need to confront issues of power that were within the COVID management. We need to confront issues of interests. Who made the rules and in whose interests were all these things made? And where was the global south? And if we are talking about global health and global solidarity, where was it when people in the global south struggled to even get vaccines? And for the UK government, it was disheartening to learn that much as they've always pushed, because in my school of law, all the cases are not about human rights. Many were cited or passed by the UK courts. But it was disheartening to see that the UK government was at the forefront of violating international human rights when it came to COVID-19. It did so when it failed to even intervene, when it blocked the TRIPS waiver that everyone thought was a silver lining amid this pandemic. The UK government violated its obligations when it's opted for secrecy, it went for trades and protected corporations at the interests of the right to health. So for how long will this go on? Yes, the pandemic has been announced as over, but as people in the global south, we're still facing pieces of it. And our health systems are still weak. The public health systems are still grappling with insufficient finances. Medical doctors are still on strike. So this will also take us into another pandemic where we shall also be very unprepared. For the UK government, we call on it to have the principles of solidarity, compassion, equity in all its foreign diplomatic policies, to take on everyone's life as one that matters. Because what it exhibited during the 3 years of the pandemic was one that Charles Darwin referred to as survival for the fittest. And for this, it was survival for the richest, because the rich people, about 10%, had their wealth multiplied 3 times, while those in the global south were pushed further into poverty, which consequences we still grapple from to date. And we cannot tackle One Health, we cannot talk about universal access unless the big powers and the decision makers are willing to redress the iniquities associated with colonial expansionism, with extractivism, and the capitalism. For this, I stop. Thank you.
Thank you so much, Labilo, and such a powerful close to the initial panel discussion. So thank you for sharing your remarks and your powerful experiences of the work you were doing during the COVID-19 pandemic with the great advocacy and campaigning of ISA. And really pleased that you're able to bring in just now as well about what action we need from the UK government going forward and the recommendations that are essential to be implemented to improve both the response right now and but future pandemic preparedness and health system. So thank you again, Labilo. We now have around 10-15 minutes for any questions, comments. that could be either directed to Manuel on the research and the report that he presented on, or to any of the panelists on their experiences and their testimonies that they shared so eloquently and powerfully during discussion just now. So Labila, Victor Badjo, Asia, and Alan. If you had a question, please do feel free to raise your hand and you can come to it, or to note it in the chat function. Vida, thank you. Feel free to come ask a question.
Well, first of all, thank you so much for all these insightful presentations and for the report. Well, I speak on behalf of the Global Action for Trans Equality as the Intersex Program Officer, and I am very glad about the report and the highlight it brings to the colonialism, and also to the racist dimensions of the COVID-19 response and research. And I am wondering if the author of the report or any one of the panelists today would be able to bring some considerations, or if in the report it's clear, it could be well, disaggregate some considerations. I know it's not in the report, but if you, in your experience of researching this, you realized any kind of inequality in regards to the access to health and access to COVID vaccines and access research and funds, and how these inequalities affected trans, gender diverse, and intersex persons. I know, Alan, from Brazil, we speak from the country that most kills travesties and trans persons, and I am wondering how you, well, if you could see any impact of not only around the racial aspect of it, but also around gender and sex inequalities on the COVID-19 response, fund, and development. That's my question.
Thank you so much for the really important question. There's some connection issues, unfortunately, but I think we heard the most of it there around the impact on the transgender community and the insights from the COVID pandemic linked to the research. Would Manuel or any of the four panelists like to take that?
Maybe I could try to answer it. So we didn't look into that specifically. It's a really interesting question, and thanks a lot for asking it. I think one of the issues that we face there is that measuring access is actually really tricky. And we end up using proxies a lot of the time because eventual access is a combination out of a lot of things. And pricing is often one of the proxies we rely on quite heavily, but obviously a healthcare system that is incredibly well endowed and has a lot of financial resources to pay for even higher prices is able to ensure access. That doesn't mean that it ensures equity, because of course this is money that is coming out of the public purse. And I would imagine that because especially a lot of trans folk fall between the cracks in even public healthcare systems, that is an issue and are then forced in many different ways, but I assume also in this space to go private, and are then especially impacted by high prices. So that is, I think, one avenue potentially through which trans people are especially impacted by this, but I'm personally not aware of any elements of our report that we would be able to draw out that conclusion very clearly.
Thank you, Manuel. But it'll be great if you're happy to share your details, Bida, to stay in touch on that point and to consider if there's any other research or how we can look to address some of those evidence gaps. Thank you, Manuel, for the answer there. Good time for a couple more questions. If anyone has anything else they'd like to raise, either in the chat or to come off mute. Also understand it's a 70-page report, so maybe not enough time to read it all, but the links are available now in the chat. A question from Sherry there on anything specific recommended for the WHO to do within the report. If colleagues wanted to address that, or maybe also to touch on a bit more around the WHO pandemic accords being negotiated now as well too, and if there's any reflections from the panelists on what more should be taken forward from our member states within that. Manuel.
I don't mean to take the mic this often, but so if anyone wants to go, please go ahead. But I do see that a lot of the recommendations that we have put forward are really relevant in the pandemic accord negotiations, and for those who've gone through the zero draft and the draft text, you can see already that especially the issue of conditions and equitable access are kind of central negotiating points. I do think to a certain degree that high-income countries have realized that this is unsustainable, and I think are in somewhat of a position of trying to do damage control. And I think are kind of taking steps in the right direction, but not going far enough to really make sure that the inequities we saw during COVID don't happen again. I think there's some systemic changes that are really amiss here in the proposals we've seen so far, but definitely the elements that we talk about, I think especially also about introducing coherent strategies, being explicit about the fact that the inequities we saw are by no means accidental, but are there by design and neo-colonial of sorts. I think that these are elements of a discussion that really need to be more be acknowledged. As for recommendations for the WHO specifically, we didn't put any into the report because really the target of the report and the focus was the UK and what the UK should support at the international stage. And of course that includes the WHO, but for the WHO itself, that would have been, I think, a different report.
Thank you, Manuel. Would any of the four panelists want to share any reflections on either the role of WHO or what we want for the pandemic accords? Asia.
I think something that I have found as an organizer is there is a great lack of trust. And I know Dr. Martin talks about systemic changes and policies that we can introduce, and there is a space for that. But there is this lack of trust that no amount of financial resources can plug. There are actions that need to be taken and need to be taken consistently, which somehow don't always get done in the right time. And I really think that we need to be mindful of that, and we need to action that, and then have these systems in place alongside and sort of work at reestablishing trust. Because in the absence of trust, we just see this entrenching of colonial systems again and again and again. And I just wanted us to be mindful and sort of call a spade, that there is a lack of trust between communities here. And we need to work at that.
Thank you, Asia. Alan, Labilo, or Elia, any reflections on that, or any final comments? Elia.
Yes, thank you, James. I think one also of points that we can give as a recommendation to the World Health Organization is that he must, as a global organization, to make the monitoring of the level of preparedness of different countries, at enough of South and different parts. What is the level of preparedness and the response? and what is the advice he can give to different states. It means it's the World Health Organization who must give us the level of preparedness and how, and they give also recommendations how things must go ahead. I think it's one of also recommendations we can give to them.
Absolutely, completely agree. Thank you. Any final reflections, Alan or Labila, before we close the meeting this afternoon? Alan.
Yeah.
Yes.
Go for first, Labila.
Maybe by way of closing, we just need to emphasize that if we are to give more life to the Almaty Declaration of Health for All, UK and the other governments of Switzerland, Germany must be willing to share that table and whatever is on that table. So this essentially means that people who have long stood at the margins of decision-making in all global health policies must be centered. And this has to be purposeful and intentional.
Thank you. A very powerful message to close. Thank you, Labila. Alan.
Yeah, no, just as closing remarks, I just would like to congratulate on the whole team on this report and say that I would like to highlight that it's used a lot of powerful words, and I think they must have consequences, you know. And I think the recommendations are very important now because one of them caught my attention. That is, we should not rely on the private sector so much. We should realize how impactful the public sector can be when we are thinking about R&D and even manufacturing and distributing health technologies. So we should not be just accepting all these conditions and realizing the power we have as people and the states themselves. So I just would say that we should not banalize these words and see that we should not just say that let's jump into the next problem because this is a really tough issue and they must have consequences.
Completely agree, and I think that's a very powerful message to close on, as we're absolutely looking for this report to drive the needed action and change from the UK and other governments. So just posted again in the chat the links to download the full report and executive summary. Our social media toolkit suggested Facebook and Twitter posts to put out on your networks and share with partners. And we've also set up an e-action with Just Treatment. So within a couple of minutes, you can send a pre-generated letter to all relevant government ministers, sharing the report and asking them to urgently take forward the recommendations as well. So please do take that action in a few minutes and share with your networks as well. The recording from this session and the full slides will be available shortly after this afternoon, alongside the full report sent to everyone who signed up via Zoom. So please do share with any of your colleagues within your networks and help drive forward taking the recommendations forward into action as well. So with that, I'd like to close again by thanking Manuel and Rhiannon for all of the excellent research for this project, for writing the report, for Open Societies Foundations for making the research possible, our excellent panelists who gave up their time and expertise for us today. So Alan, Asia, Elia, and Labila, and thanks again. And thanks for all of you for joining the call and for working with us in the Access to Medicines movement going forward as well. Thanks again, everyone.